Okay. So we'll just let our speakers sit down. So if any of you have got questions, please do come to the microphones and ask away. I've got one question onto the Twitter, which is very exciting. But if you've got your own questions to ask, please do now. Okay, well, while you're setting, I will get us started. And my sort of question I got via the Twitter was very much on, and it's my opinion as well, we don't want to particularly make MR more invasive. One of the advantages over colonoscopy is that it's a very simple test, or cross-sectional imaging. You don't have to give a bowel prep in theory, and it's non-invasive for the patient. However, a lot of most of you talked about giving enemas and water enemas to the patient. So I just want to clarify, do we have to give the water enema? So some of the data that Geordie showed there, that Finch study didn't show that much difference to my eye between non-distended and distended colon. Do we need to give a water enema, or are there some patients we don't need to give it to, and how will you divide up your practice? So maybe you take it in turns for the speakers to answer that.
I can start. As I said, I prefer giving a water enema if it's possible, but of course it is not always possible, especially in critical ill patients or in patients with toxic megacolon. Of course, you cannot, and we don't give water enema either in patients with agranulocytosis. And sometimes the patients refuse, of course. But if it's possible, I prefer it. Unless you look for leakages, then you can do a positive enema.
Can I just clarify, do you give a formal bowel preparation first? Do you give them laxative?
For colitis, I don't think it is necessary to do any bowel preparation.
Okay.
It's not the same as if we were looking for small polyps.
Okay.
Yeah, just, I think depend of the context. And in a patient, if we are dealing with patients with chronic disease that are non-Crohn disease, and maybe it's not necessary to give enema, and you generally also look for small bowel involvement most of the time, not only colon disease. And you generally give some water by mouth to give some, for bowel preparation, and that's most of the time it's okay for the colon too. And I don't think a lot of team are using barium water enema for MRI of the colon. I don't know if you have any. Do you use water? No, most of the team don't do. If we are dealing with emergency patient, and I don't think also we can give any kind of enema. We are just doing some kind of. This is different if we have patients that we are looking for specific disease of the colon. And then if you have time, no emergency, it's not chronic. Because if you give some enema, like you said, the advantage compared to colonoscopy remain limited. And I think we have to do the less involved and the less aggressive test that we can.
Yes, well, in the specific setting of IBD on Crohn's, well, we have to differentiate the emergency and non-emergency. For an emergency, maybe it's a matter to confirm the presence of activity and to rule out complications, and in that patients, we don't routinely use enema. On the other patients that are referred with from outside, from the clinicians, we recommend to reach an agreement with the clinicians just to identify those patients that can take benefit from enema or not. If we know that the patient has Crohn's disease and there is no need from part of the clinicians to evaluate the patient by endoscopy, initially we prepare the colon with an intensive cleansing, but probably it's not necessary. We are not running with this strategy, and this increases the tolerance of the enema. The second point is that we have to explain better the patient, the procedure, and also increase the tolerance. And there is a bit of learning curve. So at the beginning, and it happens in our institution, and it happens in some institutions of the study that I introduced, in the Finch study, the institution start to distend the colon a lot until the top, and this generates some discomfort on patients. But in general, the test is acceptable or better if we are getting the tolerability by most of patients, with, especially when the local sites have a bit of training. So I think that it has some advantage in clinical practice and also in research, because it improves the confidence of readers, allows better assessment of the severity of lesions in the setting of Crohn's disease. And ulcerative colitis, I'm not sure, because I'm not sure if we are going to distend the colon, we are compressing the wall and we are reducing the thickness of the colon that is already lower than in Crohn's and can mask disease. I'm not sure in that setting, but in Crohn's, definitely I would strongly recommend to distend the colon.
Okay, I'll just say in our practice, I'm involved in a study where we give the patients some oral drink about 2 or 3 hours before the MR scan. The idea that gets through to the colon, then you give them the second drink an hour before the MR, which goes to the small bowel, so like a double oral prep to try and fill both the large and small bowel. And some of our results have been pretty good, and obviously patients potentially prefer that than having an enema, but it's just another way of doing it potentially. Okay, any other questions? I think there's one at the front. He changed his mind. Okay. Anybody got any questions? Good, it's crystal clear. So I'll have to go to my list of what my ideas. And I think one of the just a quick point to make, that we always say ultrasound's got a learning curve and it's operator dependent, and that's why it's potentially a limited test. But I've just come from a scientific session where they talked about MR scanning, and there's a definite learning curve. So they looked at their trainees and looking at the MR scans, and took about 100 scans before they were up to the level of an expert. So I don't know if Sabine, if you want to comment on that about learning curves, because I mean, in my opinion, maybe not just be ultrasound, it may be all the techniques.
In my presentation, I stressed the learning curve, especially for contrast-enhanced ultrasound for colitis. I think it is true because, in fact, when doing ultrasound, you are not. The images have to be created on your own, and whereas in CT and MRI, the images are created; they are objective. It's just the interpretation which may be subjective. But in ultrasound, the images are subjective, and the interpretation is subjective as well. So I think it is. A learning curve is more important associated with ultrasound than with the cross-sectional imaging, MRI and CT.
Okay. Maybe there are learning curve for all techniques. The difference is the learning curve for ultrasound, it's the radiologist's learning curve. The learning curve for MRI, for example, is a learning curve of the team, the technologist and the radiologist, because MRI of the bowel, and especially of the colon and the small bowel, is some kind of learning. Your technology have to be able to do at least 10 a week to be able to do that in high quality and reproducibility. And that's probably the big difference between ultrasound and MRI and CT. CT is very easy to do, and the reproducibility of CT is very high. That's why most of the guidelines still recommend CT in emergency, because we don't want to miss big things. You don't want to kill the patient because of the techniques. And when the MRI will be as reproducible as CT, we don't need CT for IBD, definitely. We don't want to irradiate patients. But currently, that's mainly a problem of reproducibility.
I completely agree with the previous comments, but also I think that ultrasound has another limitation for the learning curve, that is it's a bit difficult to review the findings. By contrast, CT and MR, you can retrieve all kind of information and correlate with and review the findings. Oh, yeah, there is this tiny lesion that I was not sure what does it mean, but by contrast on ultrasound, you can just review some pictures and you miss some information. And if there is something that is missed, you don't know because it's new or because you have missed this information at the time of examination. And this may be helpful. That allows more central reading to some extent.
Maybe I can do another comment. It's about showing the image to the clinician. That's maybe the main reason that GI guys are doing ultrasound, because they show the image themselves and they don't believe us. And they believe the MRI that we show to them, but they don't believe the ultrasound. But they do the one that do it, they do believe it.
This is very institution dependent. Yes, in my surgeon, if I show you some ultrasound, like, no, show me something that I can understand. But in some institutions that with good ultrasonographists, this is not a problem because they are very used to deal with that. But it's very institution dependent.
I mean, I agree with that. I remember, just as sort of a joke, one of our registrars showing an ultrasound of a kidney to the IBD MDT, talking about the inflamed bowel, and they're the gastroenterologists were nodding away, saying that. So clearly, yeah. So I think they don't always understand what they're looking at. Any? Yes.
The frequency of the probe. You always have to start with an abdominal probe, because when you have big colon inflammatory change, you'll see it with a 3 to 5 megahertz. But as soon as you want to look to the wall, really, you have to go to between 5 to 9, and 7.5 is a very good compromise to do that. Of course, you cannot do that in obese patients. That doesn't work.
Okay, the question there. Excellent.
I would like to come back. First of all, thank you very much for the excellent reviews, before I forget it. I would like to come back again to this enema question, because I think it's quite interesting to have it in international context. How do other countries do it? And there are even different settings in different hospitals in the same country. For example, in my hospital, whenever the patient will have any type of abdominal pain, especially on the left, they will want a contrast enema with the CT. And I sometimes, even when they have the right upper quadrant pain, which doesn't really make sense to me, but you can follow me. So my question is, first of all, how is it in your different countries? Even in, I'm talking only emergency settings, right?
Yeah.
Do you usually will do an enema? And second, would you prefer water or contrast? That one of the arguments being made that with contrast you can see better where the extravasation is than if you rely on air, for example.
You don't do it white.
So with contrast enema, you mean a barium or iodinated hydrosoluble?
Of course, not barium, because we are talking emergency setting.
Pardon?
We are talking about an emergency
positive
setting, so not barium, water soluble.
Water soluble, but iodinated.
Yes.
Positive.
Yes.
Okay. Yeah, we don't use it anymore at all in emergency patients. Patients who are not too bad, no? Emergency patients mainly with a suspected diverticulitis, you mean, don't you? For example. In these patients, we do water enema. And we never use iodinated contrast medium because of the impossibility of analyzing the wall. So you can't see clearly any colitis when you fill the rectum or the colon, distal colon, with a positive, with a hyperdense liquid, I think.
If the question is, does I have to use any enema, I will use definitely water enema and not white. White will shallow and just cannot allow to see the wall and the abnormality of the wall. That water, black enema is probably the best, either for the small bowels and for the colon. Do we have to do water enema? It's a difficult question because it really depends on the status of the patient. In a very sick emergency patient, there is no doubt we cannot do it. In chronic disease where patients have, for example, MRI every 2 months for following monitoring therapeutic, we cannot repeat enema like that. You know, the patient, they will not come back anyway. And the question will be in between, and there is all range and all institutions have different practice, I think, you know, and there is no clear answer right now.
But you would say that using water enema will not decrease your sensitivity for perforation?
I don't think so, because you can easily differentiate the abscesses. You mean that? From the bowel?
I mean, for example, free perforation or gedeckte Perforation.
Diverticulitis perforation, for example.
For example, in diverticulitis.
Yeah.
No, I think it is.
I don't think so.
Thank you very much.
Okay. Any questions? I've got one last quick one, if nobody has one, but I don't want to steal your thunder. Okay, so I just wanted to pick up on, if you like, my institution, we do CTs very rapidly or very, very quickly at a very low threshold for the acute patients, even young ones. So we're getting a few cases, well, a lot of cases, where you've got a young patient, 25, 30, who has the CT scanner and the whole colon's inflamed. And when you go back to the gastroenterologist, they said, yeah, they're vomiting, they've got diarrhea, they've got a temperature. Sounds like gastroenteritis. Are you confident enough on your CT findings for that patient to stop after that? Say, this is gastroenteritis, no endoscopy, no further imaging, or do you recommend one last test just to make sure?
With the one last test, you mean colonoscopy?
Yeah. Can we say, look, this is compatible with I don't think this is ulcerative colitis, I don't think it's acute Crohn's, I think this is obviously infection, we can stop?
I think it depends very much on the clinical symptoms. And infectious enterocolitis is mostly different from the symptoms you see in ulcerative colitis because it is really a sudden onset. So in any way, I would not recommend a further CT, of course.
No, that's the problem, yeah.
This is a difficult question. At the beginning of any kind of bowel exploration by radiologists, and as soon as we are to try to see the kind of disease of the small bowel colon, we underestimate the disease at the beginning of the experience. That's the common experience. And we all say to the gastroenterologist, there is a big colon colitis, or there is a big yellow colitis, and they do a colonoscopy and say, yes, it's a winter gastroenteritis, you know. And we have to learn also and to adapt our threshold. My suggestion is either when there is diffuse disease, that is generally not so severe. When there is an ileocolitis, you are not to be worried about. You have to be worried about of this kind of ileocecal colitis, very localized, and sometimes you have to repeat. And repeat ultrasound, it's very easy to do. To repeat an ultrasound 3 weeks after there is nothing, no any kind of thickening, and maybe it doesn't need an optical colonoscopy to do that. Especially it has to be a complete colonoscopy if you want to go to see the last ileocecal and the valve.
Okay, yeah, that's a good suggestion. Okay, well, I think we should probably stop with this 5:30. So I'd like to thank all our speakers for excellent talks, and thank you for your contributions as well.
You escaped.